I would like to thank the organizer for the kind invitation to talk about fetal manifestation of HCN4 mutations. To better understand the topic, let me first briefly review how the heart rate is orchestrated and regulated, including the role of HCN4 channels in this process. As you know, the normal heartbeat is initiated by spontaneous action potential from the sinonodal cells that are then propagated across the atrium, the AV node, and the ventricles. This generation of rhythmic action potential results from spontaneous slow diastolic depolarization of pacemaker cells toward a more positive threshold potential at which the action potential is generated. Voltage-gated hyperpolarization activated cyclic nucleotide-gated channels called HCN4 channels that are located in the plasma membrane of sinonodal cells play a special role in this process. The HCN4 channels are composed by 4 subunits that are assembled around the central pore, which is at the ion conduction site. Each subunit consists of 6 alpha helical transmembrane segments, S1, 2, and S6, as well as intracellular N and C termini. The C termini is the connection site of cyclic AMP, which regulates the current of ions through the central pore. At the inflow of potassium and sodium ions during this slow diastolic depolarization is called the funny current, and the faster this funny current during the depolarization is reached, the faster the heart rate. Sympathetic stimulation shifts the depolarization curve to the left, resulting in faster heart rate, while parasympathetic stimulation or blockage of the funny current with a medication called ivabradine can slow the heart rate down. Now, because of the fundamental role HCN4 channels play in heart rhythm generation, they have become a focus of interest in research and also in to find disease-related conditions. Now, overall, there are now 29 HCN4 mutations identified with a number of mutations that are currently considered as a variant of unknown significance. Most of these mutations are a result from heterogeneous missense mutations of a single amino acid that changes the function of the HCN4 channel. So let's first talk about gain of function abnormalities that lead to faster heart rates than usual. As example, inappropriate sinus tachycardia. There is to date only one mutation that has been reported related to HCN4 channels that leads to inappropriate sinus tachycardia. Inappropriate sinus tachycardia is defined as unjustified high sinonodal rate for patient age and exaggerated response to stimuli. This is obviously not something we would be able to examine before birth. So the diagnosis of inappropriate sinus tachycardia is, for a number of reasons, not an easy one. Most commonly, this is diagnosed in adolescents and adults, associated with an increased cardiovascular risk, and it's supposedly related to some dysfunction of autonomous nervous system. Also increased in sinonodal activity has been blamed for this. Treatment can be challenging. Now, the one mutation that was detected, the HCN4 mutation, is reported by Baruscotti et al. In European Heart Journal in 2017. Baruscotti investigated, genetically tested a number of adults, overall 48, with a diagnosis of inappropriate sinus tachycardia, including 4 who had a known familial history. This resulted in 1 woman who was found to have a mutation that is affecting the C-linker function which is called R524Q, and resulted in increased cycle AMP, as elegantly shown in a patch clamp study and in spontaneous beating mouse cardiomyocytes. When they tested other family members, they found her daughter to be affected, teenager, as well as other family members. Most importantly, these patients had palpitations, but no other significant findings reported. Now, this is a patient I have seen at 16 weeks of gestation 2 years ago with incessant tachycardia at about 200 beats per minute. The fetus had also cystic hygroma, and the family history was remarkable because there was an uncle of the fetus who had congenital jet. The arrhythmia pattern shown here suggests that this is what we call a long V8 tachycardia. This is also seen here. Ductus venosus flow in this situation remains normal, as it would be in inappropriate sinus tachycardia. Now, if a fetus shows up at 16 weeks of gestation with fetal tachycardia, the usual mechanism is atrial ectopic tachycardia. Reentrant tachycardia is unlikely because the heart is simply too small to allow the reentry. Thyrotoxicosis is a rare abnormality that can lead to sinus tachycardia. It's usually due to maternal Graves' disease, and it would look exactly the same as atrial ectopic tachycardia. Now, in this particular patient, no treatment was started because of the nuclear translucency of the cystic hygroma, and the family terminated pregnancy due to suspected fetal abnormalities. The mother returns a year later at 12 weeks of gestation with the next pregnancy, this time at 12 weeks with incessant tachycardia, 203 beats per minute. There were no other fetal anomalies detected, and the pregnancy continues. Again, we have a long V8 tachycardia, as we have seen in the first fetus that was affected. We started treatment with flecainide to try to control what we thought is atrial ectopic tachycardia, and were eventually able to slow down the heart rate to something that is well tolerated, about 155 beats per minute. And as you can see here, with good function and no significant valvular regurgitation. The pattern shows still a long V8 tachycardia, and the flow is normal. Now, what we found at birth is normal sinus rhythm. That is a little bit faster than you would expect. And 3 days later, the patient is discharged with the assumption that the arrhythmia has resolved. I bring the patient back for a Holter at 12 days. And this is the tracing that you see here with an average rate of 180 beats per minute. Clearly, this patient has, again, tachyarrhythmia. The ECG findings show, and the Holter findings show that this is sinus rhythm throughout between 135 and 270 beats per minute. And we start treating the patient for inappropriate sinus tachycardia, initially with a combination of treatment. We have not started ivabradine here yet, but the child is 1 year old and relatively well controlled with a combination of a beta blocker and digoxin. Now, the situation is that we had 2 affected fetuses showing exactly the same arrhythmia type, as well as an uncle who has congenital jet. When we arranged the arrhythmia panel, we found the mutation 3 locations away from the one previously reported by Barascotti in both of the fetuses. We subsequently tested 5 more family members and found the mutation in the father of the child who has inappropriate sinus tachycardia and went on the treatment of ivabradine afterwards, the uncle with congenital jet, as well as the grandfather who had multiple myocardial infarcts before 60 years of life and has now also diagnosis of inappropriate sinus tachycardia. We found the very same variant of unknown significance at this stage in another family, again, a fetus presenting with 16 weeks with incessant long V8 tachycardia and the diagnosis of inappropriate sinus tachycardia, 3 years of life. The mother, when she was referred to us, had reduced cardiac function, and the diagnosis of inappropriate sinus tachycardia mediated cardiomyopathy, for which she underwent already as an adolescent multiple attempts of radiofrequency ablation of the sinus node. The grandfather has died after multiple myocardial infarcts and had a post-mortem diagnosis of the same mutation. Thus, compared with the one mutation of Barreau-Scotti that presented in mainly in adults and in an adolescent, our mutation clearly has effects before birth, requiring treatment and to improve the outcome of affected babies. Now, what about HCN4 channels that result in loss of function, sinus bradycardia, and sick sinus syndrome being a recognized potential diagnosis? There are currently 28 mutations reported, and I list some of them. As you can see, this mutation affects the pore function, the C-linker function, as well as the cyclic AMP binding domain. The typical pattern is really just sinus bradycardia, but often some structural heart disease like LV non-compaction, dilated ascent aorta, dilated cardiomyopathy, or sinus brady syndromes that can also relate to this type of mutations. As mentioned, there is one report affecting fetuses by the Munich group that reported 2 fetal cases 2 years ago in heart rhythm case reports. The first patient was diagnosed at 12 weeks for persistent fetal bradycardia, and genetic testing showed this mutation G482R. This was supposedly a de novo missense variance because the parents were not carriers. The child was reportedly had this structure with a structurally normal heart and just a slower heart rate than usual. The second patient has, however, a strong history of paternal sinus node disease, was diagnosed at 32 weeks with sinus brady of 112, and this is a fetal MCG with a prolonged QT, and the 36 had episodes not only of sinus brady, but also of atrial flutter. In this patient, this G482R mutation was also found, as well as in her father. The child is reportedly asymptomatic with normal sinus rhythm, had a mildly dilated ascent aorta, and what the authors describe as increased LV trabeculations. The same findings is also found in her father with a dilated aorta and elevated LV trabeculations. Other family members were not tested, but there's a strong history of requiring pacemakers, and there is one patient who died at 6 weeks of age from sudden infant death syndrome. The Munich group did not report LV non-compaction as a diagnosis. They just mentioned increased trabeculation, but the same mutation that has been reported by the Munich group has been reported by Milano and other authors showing LV non-compaction. This is the family pedigree showing there are multiple family members that have sinus bradycardia as well as LV non-compaction related to a mutation in this area. Milano actually reported other mutations that are also linked in the same area, also showing with LV non-compaction an association. Now, how the mutation that affects the sinus node results in cardiac remodeling and LV trabeculation is not clear, but this is an association that has been now reported multiple times, sinus bradycardia with LV non-compaction, even we don't understand the exact mechanism. Now, how does this relate to our experience apart from these two cases? So I asked a number of my colleagues if they have seen sinus bradycardia in patients with HCN4 mutation. And this is one that I got shared with Bettina Cuneo, so that I can show it, that has been now identified as an HCN4 mutation. As you can see, the heart rate is slow at a heart rate at about 105 beats per minute. And the mother has a history of asymptomatic sinus bradycardia 45 with normal QTC. No family history of sudden death, seizures, or cardiac arrests. The fetus has some abnormalities. As you can see, there's a VSD, and the transverse aortic arch is small. At 37 weeks of gestation, the LV and the RV both look more trapic-related as potentially looked before. So I suspect this baby has LV non-compaction as well. Now, the neonatal ECG shows a low right atrial rhythm at 105 beats per minute. And the genetic testing confirms a normal mutation that is linked in the same area as the one reported previously by Milano that resulted in LV non-compaction and sinus bradycardia. We have also seen a patient with a pattern that resembles an HCN4 mutation, although I don't have the final confirmation. This was first seen at 21 weeks gestation, when the family moved from Winnipeg to Toronto with a heart rate of 87 beats per minute, dilated ascending aorta here, and also had an interrupted IVC suggestive of left isomerism. Now, left isomerism can explain some bradycardia, but in this family, the history was so striking that we did actually not consider the left isomerism to be causative for the bradycardia. The father as such has sinus brady as well as LV non-compaction. So do three brothers were found to have multiple combination of this finding, most of them with LV non-compaction. And then there is a fetus that was originally diagnosed at 12 weeks in Winnipeg, and we saw it at 21 weeks. Now, the tracing at 28 weeks suggests that there is indeed LV non-compaction. The ascending aorta was dilated, and initially I thought maybe the valve is bicuspid because I wasn't aware of the combination of sinus brady with dilation of the ascending aorta. The child is born and has a low atrial rhythm at 75 beats per minute, as shown here. This is the echo at 1 day of life, good cardiac function, but clearly hypertrapic-related LV and RV, dilation of the ascending aorta, and the aortic valve is trileafed and not bicuspid as I had thought. This is a 10-year-old brother, sinus brady at 48 beats per minute, asymptomatic, doing relatively well, but clearly LV non-compaction, and again, dilated ascending aorta. The brother has here, that's the ECG, sinus brady, slow rate. So our family shown here shows very similar characteristic to the ones Milano presented, which this particular HCN4 mutation, D482R, or the mutation that Dr. Cuneo had that were closely located to this mutation and also affecting the pore function. So in conclusion, I would like to stress that even if HCN4 mutation have not been, almost never been reported at, in the fetus, it can present indeed in utero as a persistent long V8 tachycardia. In our situation, it was not recognized as possible fetal arrhythmia mechanism simply because it has never been reported before, and I did not even consider this as a differential diagnosis. This delayed detection and treatment, including the identification of other family members with the same mutation in my situation. Loss of function HCN4 mutation are probably rare causes of fetal bradycardia, definitely much more uncommon than long QT. But this should be considered in the differential diagnosis of bradyarrhythmias associated with LV non-compaction. I think a patient that has fetus LV non-compaction together with sinus bradycardia is highly suspicious to carry HCN4 mutations. Thank you very much for your attention.